group is populating now. So welcome everyone to Cardiac Sciences Grand Rounds for June 11th, 2024. This morning, it's my pleasure to welcome Dr. Charl Els to our rounds. Dr. Els is a fellowship-trained addiction psychiatrist and an occupational physician. He is employed as a full-time assistant registrar at the College of Physicians and Surgeons in Alberta and has engaged in a part-time civil forensic practice. Dr. Els has published several peer-reviewed papers and textbook chapters, served on several ministerial committees, the Health Research Ethics Board, as well as the Alberta Review Board. Academically, he serves as a clinical professor in the Department of Psychiatry and the Department of Medicine at the University of Alberta. And Dr. Els is also the recipient of the 2023 Queen Elizabeth II Platinum Jubilee Award for his contribution to mental health in Alberta. Dr. Els joins us today in his capacity as an assistant registrar at the College of Physicians and Surgeons in Alberta, and is going to speak to us about healthcare under the influence. Dr. Els, welcome, and we look forward to your talk.
Good morning. Thank you for this opportunity, and thank you for the invitation. As you heard, my name is Charl Els, and as you can also hear, I'm not originally from Canada. I grew up in South Africa and came to Canada some 26 years ago. The title of today's presentation is deliberately provocative, as in healthcare under the influence. And the intent here is not in any way to diminish the impact of substance abuse and addiction in individuals with in the physician health population. But the intent really is to draw attention to the notion that physicians, just like the general population, are not immune to addiction and mental illness, and we also develop conditions that may impact our ability to practice. Next slide. I have received in the last 5 years a few grants. I've been fortunate and served on a couple of speaker bureaus. I don't have any pharmaceutical or commercial conflicts of interest. As you heard, I'm employed full-time by CPSA, and I do a bit of work in civil forensic practice on the side. Next slide, please. I hope to use first person and inclusive language today, and I do ask, please email me if there's anything that you feel is not sitting right, or if you wish to contribute anything, but you do not wish to raise it during question and answer. So CPSA respectfully acknowledges that we here in Edmonton are situated on Treaty 6 territory, being the traditional lands of First Nations and Métis people. And I also acknowledge and pay tribute to the traditional territories of the people of Treaty 7. City of Calgary is home to the Métis Nation of Alberta, Districts 5 and 6 as well. Next slide. So what is it that we want to achieve today? Well, at its basis, I want us to talk a little bit about what mental health and specifically addiction looks like in physician. And at its core, it has to do with CPSA, the college, fulfilling its legislative mandate of course, guiding the profession and protecting the public. And in order to do so, there are times when we do have to address fitness to practice or fitness to work assessments for physicians. So the intent here of today's session would be to focus also on the duty to report as per the standard of practice, and also to determine what those thresholds are. What are my duties as a regulated member? And as a practicing physician in this province, I'm also subject to exactly the same standards of practice. And I do recognize these can be immensely difficult when we notice a colleague of ours suffers from a mental health condition or a substance use disorder that may foreseeably or has already impacted fitness to practice. That duty to report to the regulator is immensely difficult. And I've dealt with this on a few occasions in my own practice. I also want to speak a little bit about clinical practice guidelines for physician health programs, given the robust change that the physician health program here at the CPSA has gone through in the last 1 year. Next slide, please. So the case that I want to speak about very briefly is a 55-year-old female that I saw a few years ago. She's a health professional who came from a different jurisdiction. She had no presenting complaints. Their college didn't have any issues other than one thing. She was not paying her dues and was consistently paying it late. And the particular year, just before they referred her to me for a psychiatric and fitness assessment, she had not yet paid it, so she was quite late. And when we look at some of the work that our innovation department is doing here at CPSA, some of the predictive analytics suggest that if you pay your registration fee late, that in and of itself is not a source for professional conduct, referral, or complaint, but it is actually independently predictive of future complaints or discipline issues or even competency issues that may arise. So it's amazing how the proxy of the time when you pay your registration for your annual RIF renewal can be a predictor of future competence problems or future discipline issues. In this particular individual, I started doing an assessment. It was a face-to-face assessment. And my usual standardized, comprehensive, independent medical or psychiatric evaluation was initiated. And very early on in the evaluation, I realized something is off. So I immediately defaulted, and off, I mean, cognitively, something was not exactly right. Although as a psychiatrist, I'm not a neuropsychologist. So I'm equally at times at a loss of quantifying or even delineating what exactly is going on a cognitive level. But the bottom line here is, next slide, this individual, I thought I'm just going to do a very baseline quick MOCA test and performed the MOCA. And very specifically, the MOCA you can see at the top right-hand corner. We ask a very specific question for the individual to indicate 10 after 11 on a clock. And in this particular case, next slide, this is the result that I found. So this was an individual who was a specialist in a surgical discipline. So you can imagine if this is at the time of the assessment, the level of at least a small glimpse in a small aspect of cognitive and psychomotor functioning, you can imagine it's not a long or a far stretch to suggest at this point this individual is most likely not fit to practice. And we know because practicing medicine is a safety-sensitive job, and this is recognized by the Federation of State Physician Health Programs. Given that as a health practitioner, we work in both a safety-sensitive and decision-critical role, you need reasonably intact attention, alertness, concentration, reaction time, memory, multitasking, and a whole host of other cognitive domains to varying degrees depending on which discipline you're at or working in. Some disciplines would require much more skilled thinking when it comes to cognitive agility, multitasking, psychomotor function. As a psychiatrist, many of those domains may not be as salient for the work that we do. Next slide. So the question that we often get asked, or occasionally get asked, would be, why should a regulator concern itself with physician health? Should this not just be treated by the attending family physician or attending psychiatrist or psychologist? Why is it any of the college's business whether physicians do suffer from potential health issues? Well, the bottom line here is that the college or the regulator does have a number of different roles that I'm sure all of us are familiar with, and that includes registering physicians, credentialing physicians, supporting physician quality assurance, quality improvement, professional conduct, which I think all of us are familiar with. I've certainly had my share of that as well, but also to contribute to health policy, accreditation of facilities and non-hospital entities, but also as part of the continuing competence portfolio, which is my portfolio at CPSA, it has to do with monitoring physicians' fitness to practice. And as said, like the rest of the population, physicians are, of course, human. They're also prone to developing physical, mental, emotional, or cognitive conditions that may impact their ability to practice. So where a medical condition has impacted or may foreseeably impact the individual's fitness to practice, it is under the Health Professions Act interpreted as a degree of full or partial incapacity. And under the Health Professions Act, competence is, of course, defined as having the requisite level of knowledge, skills, attitude, and judgment to safely and effectively practice. So the reason why the regulator is involved, next slide, comes down to the very privilege and the preservation of the privilege to self-regulate. And that privilege is granted in exchange for the profession meeting a social contract. And let me explain a bit. In Western medicine, almost generally, the social contract that exists between physicians and society at large is a tacit one. Society, on their side, affords physicians a certain amount of respect and status and a mechanism for financial remuneration to perform the professional duties that they've spent so much time training for. And in return, that is from physician's side, services are rendered to society and the population, professional autonomy, and that very important privilege, not right, privilege to self-regulate and to be able to work within a particular healthcare system. So let's say, for argument's sake, as a regulator, we ignore the issue of competence and very specifically the issue of occupational capacity and the risk, which is a subset of competence. And every few days we read about a physician who potentially acted in a way because of a medical condition that resulted in harm to the population. It really is not inconceivable to think that the question of the privilege of self-regulation may be re-examined, in that if the profession cannot regulate itself, then of course the governing body, government itself, may well have no choice but to step in. So it's critically important for us, if we wish to maintain our privilege to self-regulate, to also ensure that we have a workforce that is indeed fit to practice. And when it comes to physicians, the college assumes that role, so that this privilege to self-regulate is, of course, granted under the Health Professions Act. And CPSA, or the college, is the very mechanism by which this self-regulation is carried out in a particular jurisdiction, Alberta in this case. And it includes this self-regulation, along with that tacit agreement that I spoke about, includes responsibilities on both sides of the equation. And on physician's side, it includes the responsibility, or the assumption of the responsibility that we have to ourselves as well as our colleagues to not practice if we're not fit to practice as a consequence of a physical, mental, emotional, or cognitive condition. So it's a shared responsibility between the regulator and the individual members. And the key components to this would be, and this is not captured in so many words in the Health Professions Act, but the key component of this subset of competence is indeed ensuring, in a practicing physician in a safety-sensitive and decision-critical position, to maintain a reasonable and acceptable degree of occupational capacity, as well as working at acceptable risk. Now, bear in mind, there's no such thing practicing or working in a safety-sensitive position where there's zero risk. There's always a risk. The question is, if the risk is disproportionately elevated because of a physical, mental, emotional, or cognitive condition, and if so, what needs to be done? Does that provide a basis for modifications, or what does that actually suggest we should do going forward? So the health impact is really where the rubber hits the road. Next slide. Some of the foundational concepts in practicing or in medicine is indeed that of to maintain, it's our responsibility to maintain our own fitness to practice, and to only practice when we are fit to do so, to participate in steps to regain and maintain physical, emotional, and cognitive and physical health and well-being, and also to understand what the standards of practice are by which we are indeed regulated and that to which we will actually be held accountable. Next. Okay, so when we look at the further responsibilities of a physician, it has to do with ensuring that if we're not fit to practice, that we actually take the necessary steps in order to ensure that we have achieved fitness to practice. There are steps, of course, and it's responsibility of each physician to take the necessary steps to maintain their physical, emotional, mental health so that the individual can continue to practice. And then finally, there's an incredibly important, and this is delineated in the standard of practice, there is a duty. It's not a discretionary duty, it's a must-do duty, as in to report if there is a concern with physical, emotional, or mental health. Next slide. When we started the process of changeover in the program, we started off with just over 250 files, and roughly a sixth of those files had to do with substance-related conditions. And broadly speaking, about a third medical condition and roughly a third psychiatric conditions. With the advent of Bill 46, or the Health Statutes Amendment Act, we've seen a change in the breakdown in that we no longer collect health information because that is no longer allowable under Bill 46. But what it's also done is it is allowed for us to no longer, or it's disallowed us to continue to do certain monitoring in a subsidized fashion. So that had to be divested, which we are at the tail end of that. So at the moment, we have approximately 100 members in the program that are being monitored for a physical, mental, emotional, or cognitive condition, but we do not know what the breakdown of those medical conditions are. And that information belongs to the member, as well as the member's advocate, as well as the physician health program. And in this particular case, I'm speaking about a non-regulatory body where the regulator's role now is only to look at fitness to practice. Next slide, please. So who are the disciplines who have difficulty when it comes to addiction issues? Well, the current evidence, and this is summarized by Paul Early and Chris Bundy in the latest edition of the ASAM text, and they provide an excellent summary of the most methodologically rigorous studies that suggest there are disciplines that tend to be overrepresented in physician health populations, and there are disciplines that are underrepresented. And as a general statement, across these different studies, you can clearly see that anesthesiology, psychiatry, emergency medicine, and fourthly, general practice, those are the populations disproportionately or most commonly affected. Surgery, internal medicine, and most commonly pediatrics, for some reason, seem to be the lowest in terms of the representation. Next slide, please. So there's an excellent summary also provided by the same authors in the last textbook. So I cannot take credit for this excellent summary provided, but bottom line is there's been more than 30 years of debate when it comes to the epidemiology of physician health. And there's vast differences in methodological rigor, so it's difficult to translate or to generalize the information. The other thing is when we look at the actual nomenclature, what is often described as substance use versus substance abuse versus substance misuse versus addiction versus dependence versus substance use disorder, mild, moderate, and severe. It's not consistent across studies. So very often it's difficult to translate one study's prevalence rates or incidence to a particular jurisdiction. What we can say, though, is that roughly 4% of the population at any given point, this being a point prevalence, would have approximately 4%, or 4% of the general population would have a substance use disorder. And at any given point, about 1.3, 1.4% would meet alcohol dependence, and about 0.4, 0.5% drug dependence. Looking at the lifetime prevalence, it hovers around 10% for both the general population as well as physicians. So more granularly, roughly 8 to 13%. And the profile of addiction in the population is generally the same in physicians as what it is in the general population. Now, physicians are less likely to smoke for some reason, perhaps being more aware of the risks of smoking, but they tend to be more likely as a group, as a cohort, physicians tend to be more likely to use unsupervised opioids and benzos, and they tend to be more likely to consume alcohol, and they do consume alcohol in greater quantities than the general population as a whole. And it is actually impairment within the work context that has prompted the development of physician health programs in the US. And most of the states, I believe all of the states in the US actually have some form of a physician health program, as do all the provinces in Canada. The gender distribution is males account for approximately 7-to-1 compared to females for those presenting in physician health programs, even though that is not the usual distribution in the population. So for some reason, men tend to be more likely to report. Women tend to report psychiatric comorbidity more commonly in physician populations. And as said, psychiatrists, ER docs, anesthesiologists tend to be overrepresented in these settings, and surgeons actually seem to be lower. Now, psychiatrists and ER docs also tend to be more commonly seen in AA settings, and self-reported substance use tends to be, as said, differentially expressed, and anesthesiology tend to be more expressed when it comes to cannabis and psychedelics. And in one study of the ones that were cited earlier, some 5% of physicians were anesthesiologists, yet almost 15% of the physician health programs actually consist of anesthesiologists. And there's an interesting hypothesis around it. It may have to do with a number of factors, in part because fentanyl is a compound almost uniquely abused by anesthesiologists. And there's a theory that was raised by McAuliffe, I think is the author, a few years ago, that spoke about why is it that anesthesiologists have higher rates of addiction. And it may have to do with a sensitization that happens in individuals working in an OR, specifically by the inhalation of certain fumes, be it propofol, or the actual accessibility and availability of opioids in those settings. So essentially what drives use in the general population is often accessibility, affordability, and availability. And for the general population, it's not that much different than for physicians. Which substances are used? Well, caffeine is most commonly used, followed by alcohol, tobacco among the lowest, and then of course opioids, amphetamines. All the substances are technically represented. Some 20% of programs report propofol, the anesthetic compound use. And this has increased since the attention given to Michael Jackson's death when was it, a decade ago, roughly. Cannabis use in students, medical students, the second most commonly used compound. And what is it that constitutes a risk for developing addiction? Well, it's no different in the general population than in the physician population, with the exception of the availability that may be differentially expressed. But there's a personality factor, and then genetics, as expressed in a positive family history, tends to be the most common diathesis. So on a personality level, there are certain factors like perfectionism, sensation seeking, even class ranking. The higher you rated or ranked in your class, the more likely you are to later on develop a substance use disorder. It's a risk factor. It's not the most dominant one. But there's no empirical support for an addictive personality. So that is really just a theoretical construct for which we don't find empirical evidence. But there's a very interesting psychodynamic theory that Early and Bundy speak about, and that is if you've been exposed to an emotionally barren childhood, caregiving of others may become a partial compensation or a partial repair of early deficits or early fractured relationships. And it's this very dynamic that helps professionals to do what they're good at as well, delivering care, but it may also have a dark side in that it can result in compulsively giving to others what you may not have received in your own childhood. And it's usually when this dynamic fails or falters that substance use as a form of self-medication to remedy subjective distress may potentially kick in. So comorbidity, mood and anxiety disorders, OCD, personality disorders, specifically narcissistic personality disorders or traits, as well as untreated pain conditions or untreated PTSD, those tend to be the most commonly co-occurring conditions. So really, in summary, the theories of addiction and the prevalence, etc., are roughly similar to the general population. And we know that genetics and stress and burnout can lead to self-medication, even in those who are not genetically susceptible to developing addiction. And then combined with the difficulty to ask for help, for which physicians are, of course, notorious, it can result in a lethal combination of not getting the right treatment. As physicians, and I'm generalizing, we tend to be taught to be self-sufficient, in control, have a sense of omnipotence, and combine that with the high level of knowledge as it relates to substances and drugs. We tend to sit with a sense of false omnipotence, and that is what may result in an independent psychodynamic risk factor. The sequence of impairment, it usually starts at home, and then it expands to friendship circles. By the time substance use impacts the workplace, it usually is a very serious condition, in that physicians as a group tend to protect the workplace from addiction in their own lives. And so when it does spill over into the workplace, that is usually already a dangerous sign. Next slide. So some of the questions arising would be, what duty do we have to report? And there's a number of layers by which we need to report. And not all of these would apply to everyone, but under the Mental Health Act, we have to, of course, act in the best interest of someone with an imminent substantial risk of harm. And we may need to temporarily admit that individual to the facility. I'm sure you don't deal too much with that. But the risk of harm, the Tarasoff cases in the US and what is described as Smith versus Jones in Canada, speaks about if a third party is going to be at the risk as a consequence of a physician or a patient of yours actions, then there may be a duty to report. There's the duty to report under Child and Family Services if a minor is going to be at risk. There's the duty to report fitness to drive. In Alberta, it's discretionary, of course, but the most important duty to report is the standard of practice, or the SOP. And CPSA has some 40 standard of practice and some 34 advice to the profession documents. And these represent the minimum de facto standards of care for professional behavior as well as for medical practice. And these standards are often cited when we look at disciplinary hearings or when a complaint is indeed adjudicated. The standard of practice in Alberta is that of the duty to report self or the duty to report a colleague who suffers from and whose work has been impacted or may foreseeably be impacted by a physical, mental, emotional, or cognitive condition. It's not an aspirational duty, it's a must do, and it's very difficult. I remember a few years ago in my private practice at the time, I saw a specialist who disclosed that he was using cocaine, and I didn't have a choice. And I discussed with the individual that we had a duty to report. It was quite a difficult decision, ended up reporting. The individual went into monitoring. Coincidentally, I ran into the individual a couple of years ago in a coffee shop, and the individual said to me, so deeply appreciative of having gone through the process of being reported, painful as it was at the time. But chances are, he said, he would not have recovered from cocaine addiction had he not had that external control imposed at the time. Very difficult decision. And our first step really is to decide if there's a reasonable or probable ground that the individual may potentially be engaged in unsafe practice or unprofessional conduct as a consequence of a health condition. We have that duty to report. And the first step is, and this is what I do every time, as well as I pick up the phone and speak to CMPA, even though I know full well what the likely outcome will be. But it does provide a degree of certainty that I am indeed meeting my particular duty to privacy and confidentiality as well. Next slide. So the standard of practice written based on, and I'll ask for the next slide, we briefly spoke about the Health Professions Act, thank you. Standard of practice, as said, is the de facto must do, and at CPSA there are 2 SOPs, as said, applying to this. So if you yourself, on a balance of probabilities, suffer from a medical, physical, emotional, or cognitive condition that has or may impact fitness to practice, we have to make a call. We can, of course, simply phone CPSA and say, speak to the Assistant Registrar or Senior Medical Advisor and say, I have this hypothetical case of physician X with condition Y and Z. This is these are the circumstances. Do I have a duty to report? So you can do a dry run of the scenario with no obligation. So we do recommend for members to be in contact with us and to discuss any of these questions that may arise. Next question, or next slide. Once a physician's on our radar, be it through the annual RIF or by professional conduct or self-report or reporting by a colleague, those are the four main avenues by which we would encounter physicians. But we would then expect the individual to undergo an independent medical examination, and the independent medical examination in part addresses the question of, is there a fitness to practice, the ability to work? And secondly, if there's a medical basis to require ongoing monitoring by the regulator. Those are the two big questions. Next slide. The assessment, I'm not going to go through this, and certainly the slides are available after today, but those are the basic outline items that we use when we speak about or when we expect a physician to undergo a fitness to practice assessment. And this is as endorsed by the American Medical Association, and this is appearing in Canadian jurisprudence as well. We don't have an equivalent quality Canadian fitness to practice standard, so this is the one that we defer to. Next slide. And you can populate. Thank you. So the question, and thank you, the question is who should do the actual fitness assessment? Often we hear, well, to save dollars, we need to get the treating doc to do it, but the standards in industry for safety sensitive positions preclude the physician, the treating physicians, from doing a fitness to practice assessment. And the reason for that is the treating physician has, by the very fiduciary nature of their physician-patient relationship, as a duty to care as well as a duty to advocate. So the physician treating the individual is, by their very definition, not unbiased or impartial. And when we look at a fitness to practice assessment in a safety sensitive position, we need the highest level of evidence available, and this can only be provided by an independent provider, even though they don't know the individual and they have to review background information, do an assessment, but it is best done by an individual with adequate experience in the field of occupational medicine and, be it mental health, musculoskeletal, etc., whichever the presenting pathological condition is. So this is a sensitive domain, but certainly we are following the standards as followed broadly in safety-sensitive industries. Next slide. So when an individual then goes for an independent medical assessment, most of these assessments would be substance use and or mental health issues. I have the good fortune of being the author of the best practice guidelines for the American Medical Association for mental and behavioral disorder IMEs. This is a standard, is available in public or open domain. Have a look at it. We generally, whether you use this one or whether you use a standard comparable one, it doesn't really matter as long as there is an empirical process that has indeed been validated through a peer review process. Next slide. Then, when individuals enter into a health program, there are guidelines, which are called physician health program guidelines, as issued in, I think it was 2018 or 19, by the Federation of State Physician Health Programs. And we tend to defer to these as the baseline or as the common knowledge in terms of decision making as to where to proceed. Next slide. So why would a physician member not seek help? Well, there's a number of reasons. The two most important ones would be actually fear of stigma. And the next one is the fear of the consequences, as in the potential for loss of the individual's license, namely the professional consequences. There is, of course, a legitimate case to be made that physicians just may not recognize addiction when they suffer from it themselves, or there may be that false sense of omnipotence in that I can control the use, even though the objective evidence may suggest that the individual is already impaired. Next slide. The model we follow in continuing competence is that which is called the Cambridge model. And the Cambridge model speaks about performance, competence, but it also recognized that the individual related influences may impact the physician's actual performance. We recognize both individual factors as well as system-related factors. Next slide. Then the focus on competency-based assessments is really what we follow here in Alberta. And in essence, it addresses the fact, as said, that there are a number of system factors, and we recognize that for a physician to perform at the optimal level and for their competence to be optimized, we need to address both individual factors as well as system factors. So this really has to do with a shared responsibility in terms of where we try and intervene in modifiable risk factors. Next slide, please. And then we're approaching the end, and we should have about 15 minutes or so for questions. And I am going to just switch to a different camera in 1 minute when we're done with the presentation. But more than 90% of physicians are actually back in practice at 1 year. So physicians, yes, we have different income, different education, different status, but we're not all that different when it comes to addiction. But when we look at the models for addiction care and monitoring and surveillance, or shall I say oversight by the regulator, physician health programs tend to outperform, vastly so, outperform treatment programs in the general population. And it's a very optimistic particular outcome that we are witnessing in physicians themselves. So if we can replicate this kind of successful outcomes in the general population, we actually would go a long way to improving the actual health of the population. So I'm going to stop with this and be available for any questions or if there are any comments. Thank you.
Thank you so much, Dr. Els. So we'll open up the floor to questions. People can either put questions in the chat, we'll open up the box, or just turn on their mic and speak up. I'll ask a question off the bat, Dr. Els. As people in leadership of sections, when people are kind of returning to practice, there's privacy concerns about where they are and whether they'll be able to come back. How would you advise people who schedule and are involved in bringing people back into practice to interact and understand someone's ability to return to practice, and where should they seek information on ensuring that person is cleared to return to practice?
Thank you. That's an excellent question. My apologies, just dealing with a small tech matter here, but it should be good in 1 second. Okay, I'm back. Hopefully you can hear me now. So
yeah, we can. That's great.
Okay, that's better. My apologies. The challenge of privacy and confidentiality is one that we take incredibly seriously. And the reason for that is, if we do not pay adequate attention to it, you can conceivably imagine that it would drive physician illness underground completely. If I do not know what happens to my medical information once I've reported to CPSA, for example, chances are I'm not going to report, and most physicians would not actually report. So that is what Bill 46, the Health Statutes Amendment Act, actually helped us achieve as well. Under Bill 46, CPSA can no longer collect health information. So that means that the level of privacy and confidentiality is actually unparalleled compared to Bill 46, along with all its deficits and challenges. This is probably one of the strongest elements. So let's say you have a member of your department who clearly has an issue on a balance of probabilities. You have a conversation with them and indicate, well, under the SOP, I would have a duty to report. Here is the objective evidence that's been observed by X, Y, and Z. It's nothing personal. It's just we all suffer potentially from conditions. You need to self-report to CPSA's health department. It is firewalled off from the rest of CPSA. The information you're going to speak to them about does not go to complaints or anywhere else without your explicit consent. If the member does not self-report, you also as a regulated member would have that duty to report. Difference now is CPSA only wants to know there's a health condition, no information on what the health condition looks like. It's a difficult equation, but then we would send the individual for be it a focused or a regular independent medical exam. We do not get the health information that is collected during that, along with the previous reports, etc. There's an independent third party that's been vetted, and we have about 20 of those on a roster at the moment. The roster is open. Anyone can sign up to do these assessments. Once you're on that roster, you would collect the information, and CPSA only would get information on occupational capacity, occupational risk, basis for monitoring, basis for limitations, restrictions, modifications, and duty to accommodate. So that is it. So in essence, the protection of privacy and confidentiality is better than what it's ever been, and CPSA carries no knowledge. Now, for you as be it head of department or even potentially employer, there needs to be the same level of firewall maintained within limits, between you and the actual health information of the individual. And we achieve that by establishing occupational health focus areas within employment settings. And different employers, the largest employers in Alberta, tend to have these well developed simply by virtue of be it resources, experience, etc. But for example, within a university setting, it is equally well developed so that you can only report the presence of a medical condition that may impact the ability to do the work, which may be the basis for limitations or restrictions. But technically, that could be the only information that is obtained by you, be it head of department or employer. The OC health department, with hopefully an OC health nurse, would be the one collecting more information under the guidance of be it consultative or attending an occupational physician who may access much more information. I'm giving you just a glimpse of a fairly complex big picture model, but when it comes to protection of privacy and confidentiality in the context of employment as well as academia, theoretically, we can achieve at this point probably the best levels of protection of privacy and confidentiality we've ever had. But it does take the discipline, of course, to implement those. And if they're not readily in place, to take the steps to put them in place. And certainly, we're very happy to provide a bit of info on how we recommend physician privacy is protected. But for other workers within the setting, there are OC health consultation services. So I've given a long answer to a short question. I hope it answered it. If not, please pose a follow-up question.
Yeah. No, I think that gives me a good sense. Thank you.
Thank you.
Other questions from the group?
How do you, can you hear me, Andrew?
Yes, thanks. Hi, Catherine.
Okay. When you're trying to incorporate someone back into your group, how do you make that a positive interaction? Because you will have individuals that may not know, you may have individuals that know too much, and you want to support the individual. You don't want to kill them with kindness by overprotecting them. You want them to feel welcome and supportive. Is there a way of doing that, or what do you recommend to small groups to be able to do that?
Yes, thank you for the question. You raise some very important points, and that is clear is kind, and often killing with kindness doesn't do anyone a favor. And very often individuals who are the consumers of mental health and or addiction services will tell us that you don't have to treat me as though I'm fragile. I'm a normal human being. I'm suffering from a bona fide, a chronic relapsing medical condition. I can be treated like the rest of the population. So again, I'm paraphrasing that, but the point being, you raise an important aspect here, and that is how do we treat people so that we actually, on the one hand, balance their ability to achieve maximum medical improvement, but at the same time, maintain privacy and confidentiality, while at the same time ensuring a preservation of dignity. And that's a fine balance at times. And of course, all of us make mistakes. So the way I approach it when I'm asked to discuss this, be it with an assessment individual, and I don't assess physicians, that would be a conflict, but in other safety sensitive workers, when I have this kind of discussion with them, I do speak to them and indicate, I don't know the full picture. I'm not even that fully familiar with the particular job you do. I have a good idea as an occupational psychiatrist. So please forgive me if I'm making mistakes. If I use the wrong pronouns, let me know. But you know what, let's just engage in a discussion. My job is to help you achieve the same outcome as what you want to achieve. So why don't we jointly move forward? And please redirect me if I'm not saying things right, or if I'm saying something that doesn't sit right. It's an educational process for me. So coming from the angle of what we would describe as cultural and technical humility goes a long way to allowing people to be more forgiving when obviously we will be making mistakes, as I know I certainly do on a regular basis. So the next thing is to, I would suggest, create a sense of curiosity within your core team as to what does this look like? How does this impact us? How do we best deal with this? Because my child may have the same condition, a parent of mine may have the same condition, my peers may have this. Who knows, I may even at some point be diagnosed with a condition that may impact my ability to practice. So combining that sense of curiosity with the sense of humility within the context of focusing on the mutual goal for outcome usually gets us where we need to be. And of course, we don't always have the answers. And if there are questions posed that I don't know the answer to, I don't have it readily available with a reasonable degree of certainty, then I indicate I'll get back to them. And again, it requires a degree of humility to do so, because I think as physicians, we often, as I said earlier, train to be in control, train to have the answers, and at times, and maybe to our detriment at times, be the rescuers. So I think the approach I've outlined in very broad terms would get you a long way, and then just be honest and indicate, you know, this is where we're at. I've never dealt with this situation before. Let's mutually navigate this going forward. Does that answer your question?
Sort of. I was
okay.
I was thinking in terms of preparing the group to have an individual come back without maintaining privacy and having a supportive environment for them. And you know, how do you make it supportive and not invasive, I guess?
Understood. Okay, thank you. No, that's an equally important question. The challenge, of course, is as be it employer or fellow academics, or where the decision is made by head of department or a decision maker, there's no right to disclose even the fact that an individual has a medical condition, even if you don't know what it is. So often in addiction recovery, one of the steps that's suggestive of a higher level of consolidation of recovery, in other words, of how well they're doing and what the prognosis is going to be, is measured by the individual's ability to integrate the diagnosis into their own personal narrative and professional narrative. In other words, to be able to accept it, get past the denial and the sense of it didn't happen. So the cognitive distortions that may happen as a consequence of this are overcome, and the individual is able to disclose in a limited fashion, yes, I've been on medical leave for this time, I'm dealing with a medical condition, or I'm dealing with addiction, or whatever it is. It's a decision that only the individual can make, the degree of self-disclosure. But very often it's found that the better or the more open disclosure there is, the better the individual has consolidated their own recovery. So even though the individual needs to make that decision, the team needs to be able to have at least some explanation. And very often, if there's the impression that we are concealing information, people will speculate to fill the vacuum of knowledge, and they'll make up whatever conceivable story may be there to explain why an individual's not been there. So it doesn't serve anyone well to be overly secretive, but as said, it's only the decision of the individual suffering from the condition. So by speaking to those closest to them and garnering support from them is probably a first step. For the entire team is, without in any way disclosing what's going on, is to make sure that individuals understand that following an absence, that we now are back to usual. And again, depending on the level of self-disclosure by the individual, it may at times come across as a little mechanical, as in we're unable to share information. It's not the ideal situation to have zero information, as opposed to have at least some information that individuals can hang the hat of questioning and curiosity on. So it speaks about the individual and for them to have a safe space, and then for the team to have sufficient validation in that they are part of a team. They do have some level of knowledge and understanding of what happened. I don't have a perfect answer for you in terms of how to do it. It's navigating it one day at a time, and of course, making sure that privacy is protected and encouraging the individual who does suffer from it to consider in discussion with their treatment provider what the most appropriate level of self-disclosure would be. And aside from that, just because someone suffers from a medical condition doesn't mean we treat them differently. Of course, if there are areas or a medical basis for accommodations to the point of undue hardship, we have to honor that. But those are more formal approaches. And if anything, individuals often say that the sooner things get back to normal and it's business as usual and people forget about the fact that I was gone, the better. Not the ideal outcome, but very often that is the point that people aim to achieve. Thanks for your question.
Thank you for the answer. Good. That was helpful.
Thank you.
Other questions?
Can I invite anyone and everyone? My email should be in the presentation. There is a PDF copy of it. So at any point in time, please come and have a coffee with us at CPSA or in a coffee shop close by. Just come and chat about stuff. Don't have to mention names, but please come. You're a co-stakeholder in this business, just like I am. And I speak to colleagues as well about when I have these questions. So please take the liberty and come and speak with us. Our job is, of course, to serve the public and guide the profession. And we're doing the best we can in the interest of preserving self-regulation. So please press upon us and come and chat with us.
Great. So with that, thank you very much, Dr. Els. It's been wonderful hearing from you and very useful to us too.
Thank you, Kai.
Have a good day, everyone.